Hello, my name's Mervyn Singer. I'm at University College London in the UK, and I'd like to talk to you about cholesterol as a potential therapy for sepsis. Conflict of interest. We're trying to get money funding to look into this in more detail, but I'll show you what I hope is some interesting pilot work. So cholesterol has many roles within the body. It's the substrate for producing corticosteroids, mineralocorticoids, sex hormones, vitamin D, bile acids. It's an integral part of cell membranes. I'll talk about this in more detail later, but it controls the fluidity and the permeability of the cell membrane, ion channels. It has a signaling role, and it's also responsible for dictating the expression and the activity of receptors on the cell membrane, such as G protein coupled receptors, such as the adrenergic receptor, and you'll see therefore the relevance with sepsis. It's also important in nerves, conduction and protecting the nerves, and it has roles in immunology and actually as an antibacterial. So it's useful for neutralizing toxins and has an anti-inflammatory effect. So many roles. And many of these are affected in sepsis. What do we know about cholesterol and sepsis? Well, plasma cholesterol levels have been known for many years to fall early in sepsis. And the degree of fall is associated with a poor outcome. Now, is this just an epiphenomenon, or is there a cause and effect? This is a meta-analysis of 29 studies, collecting a total of over 33,000 patients. And they reported that HDL and LDL levels were reduced in the vast majority of these patients. This study from Vancouver shows, as I mentioned before, the prognostication of, in this case, HDL cholesterol. Levels below 25 milligrams per deciliter related to a much worse outcome. And these investigators also found that it was the best prognosticator of those things they looked at for the development of multi-organ failure, even better than, for example, lactate. This is some work from our hospital looking at patients who either survived or didn't survive septic shock. The blue represent the survivors, and the yellow bars, the shaded areas, represent the normal range. So you can see patients who eventually went on to die had very high levels of troponin T and B natriuretic peptide as a marker of myocardial injury and dysfunction. Catecholamine levels were high throughout. The cholesterol levels, the normal range is about 1 to 1.4, but they were reduced in survivors, but markedly reduced in patients who eventually went on to die. We've replicated this in an animal model of fecal peritonitis. This is a 3-day model I'm just showing here, data at 6 hours done by Vic Kalik in my lab. Early on, you can see the non-survivors, shown in the red bars, have much higher levels of troponin compared to either surviving rats, shown in the yellow bars, or control animals. And this model can go on for 3 days. So you can see that even at 6 hours, there was this marked increase in troponin. The same was seen for BMP. The stroke volume was significantly impaired in both survivors and non-survivors, more so in non-survivors, and the catecholamine levels were equally raised in both groups compared to sham. The cholesterol levels fell more so even at this early stage in non-survivors, and that was seen in HDL cholesterol for both. I have an interest long-term in the heart and with working with many lovely colleagues, and it's well known that myocardial depression occurs frequently in sepsis. It's a marker of poor prognosis, and we know that there's decreased sensitivity to catecholamines. Cardiac output isn't increased, augmented to the same degree as a healthy person when epinephrine is infused or dobutamine is infused. I mentioned lipid rafts earlier. These are within cell membranes, and they're very rich in cholesterol and sphingolipids. And the lipid rafts, there are two types, caveoli and planar rafts, and they actually are co-located with the adrenergic receptors and ionotropic receptors. So you've got ionotropic receptors, G protein coupled receptors, and many studies have shown that the beta 2 adrenergic receptor activity density is dictated by the level of cholesterol in the membrane, in particular in the lipid rafts. Going back to our rat model, this is work done by Anna Clayman, looking at the cholesterol content within cardiomyocyte cell membranes. And this is at 24 hours after peritonitis in our model. And you can see that the cholesterol levels in the cell membrane are significantly reduced, more so in the non-survivors, the eventual non-survivors. We can predict this using echocardiography at 6 hours very accurately. If you take septic serum from these animals and incubate it with cardiomyocyte cell lines, even after 2 hours compared to incubation with healthy serum, there's a significant fall in the membrane cholesterol content. What about cholesterol therapy? Nothing new. This is from Bayer, the drug company, in 1910. They took out a patent for making cholesterol as a therapy, and they used it in a variety of infectious conditions. This is a paper from Berlin in 1910, theoretical considerations about cholestearin, which is cholesterol, in blackwater fever, malaria, as a remedy. They've also shown papers of its use in pneumonia and in syphilis. Going back to our animal model, we looked at the effect of giving cholesterol on myocardial performance. So after the animals were instrumented and allowed to recover, they got an injection intraperitoneally of fecal slurry. Control animals didn't get them. And after 2 hours, 10 mils per kilo per hour of fluid was commenced. And at 6 hours onwards, we started an infusion, either of placebo, HDL cholesterol, or a cholesterol within a liposomal preparation. Dobutamine was given at 21 hours, run for 10 minutes at 10 mics per kilo per minute, and we measured before and after hemodynamic parameters. After a washout period, the same was done with norepinephrine, 10 mics per kilo per minute for 10 minutes, and then a washout period with lots of measurements in between of echocardiography and blood pressure. After this was complete, the animal was sacrificed and we took lots of tissues and blood samples. Just to talk you through this, so the dobutamine before after is shown in blue, norepinephrine in red. So in the sham healthy animals, giving dobutamine, not surprisingly, increased stroke volume, and norepinephrine, not surprisingly, increased the blood pressure. That's what we expect. However, in the septic animals, giving dobutamine, there was no effect on stroke volume, and giving norepinephrine, there was only a minimal effect on blood pressure. Giving the liposomal cholesterol, however, we were able to restore the dobutamine response to that seen in a normal healthy animal, although there wasn't much of an effect on blood pressure via addition of norepinephrine. The same with HDL cholesterol. A nice response in terms of ionotropic activity, but not much response in terms of vasopressor activity with norepinephrine. When we measured cholesterol levels, giving the HDL cholesterol, there was a very high level in the plasma. With the liposomal cholesterol, this seemed to keep the same level as in plasma, and the cholesterol's delivered within the cell. And when we looked at the heart membrane cholesterol content, that was restored with both the liposome and the HDL cholesterol. So in summary, cholesterol falls in sepsis, both in blood and in heart membrane. I haven't shown the data here, but we've seen it in liver membrane as well. And the degree of fall is a good prognosticator for a poor outcome. This responsiveness problem with catecholamines is well recognized in sepsis, and it decreases both in patients and in our animal model. So we saw less dobutamine effect on stroke volume, less norepinephrine effect on blood pressure, and that could be restored by infusing cholesterol, at least in terms of the stroke volume response, though not the pressor response. It may be related, we're looking into this at the moment on beta adrenergic receptors, though presumably the lack of effect on alpha receptors means it targets the beta receptor. Clearly, more work's needed to be done, but potentially there may be a role as a therapy for man. Liposomes are currently in clinical use, and you can have different types of liposomes for different circumstances. HDL is a very big molecule that would need to come from blood donors. I'll finish there, and thank you very much indeed for listening. I'd like to acknowledge in particular Anna Kleiman and Charlotte Gaup in my group, and my great collaborators in the Jena University Hospital in Germany, Adrian Press and Professor Michael Bauer. Thank you very much indeed. Eat butter.